Good afternoon, everybody. I am Sarah Dash, President and CEO of the Alliance for Health Policy, and I want to welcome you to week 6 of our COVID-19 webinar series. For those who are not familiar with the Alliance, welcome. We are a nonpartisan resource for the policy community dedicated to advancing knowledge and understanding of health policy issues. We launched this series to provide insight into the status of the COVID-19 response and shed light on remaining gaps in the system that must be addressed to limit the severity in the United States. The Alliance for Health Policy gratefully acknowledges the National Institute for Healthcare Management Foundation and the Commonwealth Fund for supporting our COVID-19 webinar series. You can join today's conversation on Twitter at the hashtag AllHealthLive and follow us at AllHealthPolicy. Now, I'm going to introduce our panelists in a minute, but we want you all to be very active participants in the discussion, so please get your questions ready. Here's how you do it. You should see a dashboard on the right side of your web browser with a speech bubble icon that has a question mark. Go ahead and use that icon in case you have any technical issues, as well as to submit your questions. We will collect them throughout the broadcast and address as many as possible. Finally, check out our website, allhealthpolicy.org, for background materials and a recording of today's webinar, which will be made available soon. About 1 in 5 Americans, or 60 million people, live in rural areas. Research shows that these individuals are at a higher risk of both poor health outcomes and face more substantial socioeconomic disadvantages than their urban counterparts. As COVID-19 continues, these health disparities and barriers to healthcare access are making it more challenging for rural health systems and providers to care for their residents. Today, I'm pleased to be joined by a group of distinguished panelists who will help us discuss the unique challenges facing rural health systems and highlight current and future policy solutions. First, we are joined by Dr. Michael Brumage, the Medical Director of Cabin Creek Health Systems. He is also the Director of the Preventive Medicine Residency Program at West Virginia University School of Public Health and a Medical Officer at West Virginia University's Injury Control Research Center. Next, we will hear from Scott Graham, who is the Chief Executive Officer of not one, but 2 rural hospitals, Three Rivers Hospital and North Valley Hospital in Washington State. Finally, I'd like to welcome Dr. Jacob Oren, who is the Director of the Center for Rural Health and Health Disparities at Mercer University in Macon, Georgia. Thank you all for joining us today. I am now going to turn it over to Dr. Brumage for some opening remarks. Go ahead.
Thank you very much, and thank you for the opportunity today to talk about rural health in the COVID-19 pandemic. Next slide, please. So rural health was already in a precarious position before the pandemic, with a reduced life expectancy of almost 2.5 years relative to large metropolitan areas. Some of those drivers for this discrepancy in longevity include the opioid crisis and the other diseases of despair as described by Case and Deaton from Princeton. We talk about the opioid crisis as an epidemic, but really it's an epidemic of epidemics, more properly termed a syndemic, with overdose deaths, hepatitis B, hepatitis C, which happens to be the #1 infectious killer in the United States, increasing amounts of HIV, primarily from sharing needles from drug use, injection drug use, abandoned children, neonatal absence syndrome, and first responder burnout, among many of other types of conditions with the opioid crisis. We also have adverse childhood experiences that impacts mental and physical health well into adulthood. And we have to pay attention to the social determinants of health, where people in rural areas are disproportionately affected in terms of housing, transportation, education disparities, economics, and access to nutritious food. Next slide, please. Hospitals closures are a really big problem throughout rural America, with 161 closures nationwide since 2005. In 2019, 18 rural hospitals shut down, and 2 rural hospitals in West Virginia, my home state, have closed since the pandemic started, something that's really difficult to imagine, to close a hospital in a pandemic. Likewise, the public health infrastructure has been hollowed out at the federal, state, and local levels. The Prevention and Public Health Fund from the CDC uses roughly $625 million a year to state and local initiatives for things such as immunization of children, grants for local needs, and programs to respond to infectious diseases. According to a Trust for America's Health report from 2013 to 27, the fund will receive nearly $12 billion less than the law had promised, and we see now the costs of neglecting our public health infrastructure in the trillions of dollars. Next slide. There are some bright spots, however. One of our safety nets include federally qualified health centers, which I'm the chief medical officer of one in West Virginia. They serve between one out of every 12 Americans nationwide, and 1 in 4 West Virginians, and typically these are underserved populations. In states that expanded Medicaid, West Virginia being one of them, we've seen some success. West Virginia was among the most successful, if not the most successful, with a 55% reduction in uninsured from 2013 to 2018. We were the last state to report COVID-19 cases, and therefore we had more time to prepare. So we feel somewhat of an advantage in that regard. And so far, we are the least affected state overall relative to our population, even though we have the most at-risk population in terms of age and comorbidities, according to a report from the Kaiser Family Foundation. As of last night at 10 p.m., West Virginia had 929 cases and 26 deaths. However, we do know that the number of real cases that are out there are vastly undercounted. Next slide. Some of the strategies moving forward that we already have implemented, and here you see a picture of a tent outside one of our clinics. This is a former middle school in Clendenin, West Virginia. And we use this tent to screen respiratory patients from non-respiratory patients and do actual COVID testing inside this tent where there is more airflow. We have a big shift to telemedicine right now. I would guess around 80% of our encounters are telemedicine. The future, it revolves around testing, both molecular and serology testing, tracing, and with that tracing, putting people who are ill in isolation and quarantining their close contacts, and hopefully we'll have an effective and safe treatment down the road. And of course, the holy grail is a vaccine, which is, there are several right now in human trials. That concludes my opening remarks, and thank you.
Great, thank you so much, Dr. Mike Brumage. Now I'm pleased to turn it over to Scott Graham.
Thank you for having me and inviting me to speak today. I've been asked to speak about what it's like as a hospital CEO in a rural community, and as was mentioned at the outset, I'm responsible for 2 critical access hospitals in rural Washington State. We have not seen the patient surge in the rural portions of the state like they are seeing in the more urban areas. In our county, we've had 14 test positive, and that's been since April 21st that it's held steady at 14. 13 have recovered or are in recovery. We've had no deaths. So the net effect of the guidance to be doing social distancing and stopping elective surgeries has been to essentially dry up our patient volume, and as a result, our patient revenue, our financial revenue. And it's been an interesting response from the community. We've seen folks who are exhibiting signs of panic and fear, all the way to complete and utter disbelief that there's a pandemic going on. As Dr. Brumage mentioned, there have been many critical access hospitals and rural hospitals that have been on the brink of financial closure for a long time, and Three Rivers Hospital, one of the hospitals that I'm at, was one of those hospitals that was really struggling, and really didn't have any depth in terms of financial reserves. And so when our patient volumes dried up, we were really looking at what steps we would need to take in the event that we needed to close. All that happened in a breathtakingly fast fashion. one week we were really concerned about how we were going to be able to ramp up, make sure we had enough PPE and enough equipment, beds, and so forth, and really not thinking in terms of financial disaster, but thinking in terms of how do we make sure that we're there and in enough numbers for our community. But when the social distancing affected the patient volume to the degree that it did, we were really faced with would we be able to stay in operation? And as we looked at our days cash on hand, we were essentially looking at about a 2-week window before we would not be able to make payroll. And it's a bizarre place to be, that in the middle of a pandemic, you're worried about being able to stay open as a hospital. So our work has been along 2 tracks. As a result, we've been working with state, county, and federal officials to try to find ways to get funding to keep us going. And at the same time, we're trying to ramp up and make sure that we have plenty of equipment and so forth to keep ourselves in a position to be able to take on patients should there be the surge. We're also coordinating throughout the county with all of our healthcare partners and public health. We hold multiple round-robin calls per week and just assess where everyone's at and share data, which has been really useful. And we continue to work with the state association, who's been very helpful and very supportive of our Three Rivers Hospital in particular, and helping to find ways to keep some financial help flowing to us. Also, we work very closely with Senator Patty Murray's office, who's been very helpful, and we've been working with a variety of other partners to make sure that we can continue to find the PPE that we can get and the testing materials that we can get, although much of that is still on back order due to the supply chain problems that are present. Lessons learned so far. Again, something that I would have never anticipated, that when you're in a pandemic and social distancing is required, that your patient volumes are going to drop, and as a result, your revenue is going to drop. The lean methodologies that I was schooled in years ago, and many of those don't apply in a situation like this. The just-in-time inventory puts us at a disadvantage in a time like this when we're trying to get materials and can't get them. And one of the instincts that we're trying to not indulge in is hoarding. But unfortunately, this sort of lends itself to wanting to be as self-sufficient as possible and hoard as much as you can. We were also, I think, a lesson learned is how quickly things can turn, either to the point that you cannot operate, with how quickly this pandemic spread. I don't think any of us were prepared for the speed with which this pandemic moved throughout the state and throughout the nation. And then finally, I don't think it's in most CEOs' DNA to talk about financial problems in the public. And I was actually quite nervous about doing news interviews and talking about our concerns and what we were going through. To be honest, there's a lot of shame that goes with that. You're supposed to be successful. You're supposed to be making a difference in terms of financial viability. And we were on the brink of closure. We were talking with our attorney. We were talking with the state association to find out what has to be done in the event that we have to close. But what I found as a lesson is that by being honest, forthright, frank about these kinds of things, that actually that was where we started to get the assistance that we needed, the attention that we needed, and actually the support that we needed. The community has stuck by us. Our staff have stuck by us. We've seen a great round of support from partners that we've always collaborated with, but there seems to be an even stronger bond that's been formed as a result of this. So I think those are the lessons that I've learned so far, and I know I'm learning more as every day that passes. So thank you.
Thank you so much, Scott. And I look forward to getting into some more of those lessons learned and appreciate your really sharing your leadership perspective as well. So next, I'm pleased to turn the mic over to Dr. Jacob Oren. Jacob, go ahead.
Well, thank you, Sarah, and thank you to the Alliance for the chance to talk about what we're seeing in the policy arena with regards to the effects of COVID, particularly on rural America. I do want to mention this is a particularly personal issue to me right now as a resident of Georgia. I don't know if most of you are aware, but we have one of the worst hotspots in the country, and it's not in Metro Atlanta. It's in rural Southwest Georgia, where more people have died than in Metro Atlanta. So next slide. I'm going to talk a little about what solutions have been put in place, where we still have remaining issues, and what the policy levers are that can be activated for rural America in particular. Before I go into that, I do want to highlight and just follow up on what Scott was mentioning, that the impact of what we're seeing of COVID in rural America is twofold. We have the increased cost of preparing for the surge in cases and the risk that's placing our providers in, and that's sort of the public face of the medical side of this outbreak. But the other side is the dire economic impact that is happening as revenue streams dry up for rural providers. So the healthcare hit really is twofold. So as Scott mentioned, we're asking people to solve the crisis at the same time that they're weathering the same economic impacts as other industries. But to help weather this, there have been a number of solutions that have been put in place at the policy level, and I do want to highlight just a few of those. And the interesting thing about these is that these are actually solutions that we've been proposing for many years in rural health. So the reason that they are effective right now is that they solve some of the core issues we see in rural healthcare: accessibility of care, transportation, et cetera. So it's been good to see some of these rural models be implemented nationwide. So one of the first big changes that we've seen, of course, is in telehealth. So the first big one that came out was reimbursement parity that helps ensure that telehealth encounters are reimbursed at the same rate as face-to-face. That previously was not the case. A lot of people didn't know that. So that was a big change that has allowed providers to expand out into telehealth in ways they couldn't financially have done before. The other big change there has been allowing home to be a presentation site and even a distant provider site, where you can have an encounter between a patient who's at home and a physician who's at their home. And so having that is dramatically expanding access to care. Previously, that was only allowed under specific diagnoses and situations. So this has been a big expansion. Briefly, I'll just mention pharmacy. Most of us have probably been personally touched by this. We've been allowed now to have early refills. Pharmacists have the authority to refill maintenance medications without physician prior approval. And then there's been a lot of expansion of delivery in 3-month fills of scripts. And so that's been a big advancement. The funding streams I'm going to touch briefly on, but I'm going to comment more on the next slide on these in terms of where we could see some improvement in the area. But one of the big things that happened pretty recently is the suspension of the 2% Medicare sequestration. And so that has directly brought funds back into providers and hospitals who have a Medicare census. So they're receiving that cut back during this time. The next two are ones that address sort of the secondary side of this, of the economic impact. So the SBA Paycheck Protection Program and the Economic Injury Disaster Loan Program. I have stars next to those because we all know that those funds have dried up, but with the bill that passed yesterday in the Senate, this might loop back around. And then the CMS Advanced Payment Program has been a really critical tool that allows providers and hospitals to draw down funds early. So essentially to draw down 3 months of an advance payment in Medicare funds. But there are some limitations again to that hit rural areas in particular that I'll talk about on the next slide, please. So the remaining issues though that we see is, of course, we have the lapses in funding. So the Paycheck Protection Program and EIDL, the funds have lapsed currently. Then there is the burden beyond COVID care, as has been mentioned. So the fact that we're trying to figure out how to make payroll in the middle of a healthcare crisis. But then there's also some aspects of the healthcare uniqueness. So under the Paycheck Protection Program, the forgivable portion of the loan doesn't apply to salaries in excess of $100,000. Well, within the healthcare industry, that means you can't use it to cover all of providers' salaries because of that cap. So that it does still provide some relief, but not at the same level it could in other industries. But then on the upper right side here, we see some of the lingering issues that are kind of rural specific. So I mentioned the early drawdown that's available through CMS now, but the issue there is that in 3 months, those costs are going to start to be recouped. And so for hospitals and providers who are already on the brink, and we know that over 40% of rural hospitals operate on a negative margin, the prospect of 3 months from now having to not receive their Medicare reimbursements because Medicare is reimbursing this or is recouping this cost is something that, while it might provide an answer in the short term, we could see some real long-term disastrous effects of these drawdowns. The next side is the fragility of the provider system. So when you're working in a rural community that has one hospital, if that hospital closes, we have lost care entirely. And so the system itself is so much more sensitive to these types of changes. If a local provider becomes exposed and has to self-quarantine for 10 days and they're the only provider in the community, all of medical care has been lost. If they have to shutter their doors because they don't have the income stream, the whole system is closed. So there's a lot more fragility of the system, and we need to look at how we're specifically stabilizing the rural aspects. I'll just briefly mention broadband inequity. This is something that's pretty widely known, but we do have broadband gaps in rural communities far beyond what we see in urban. And some of the solutions that we've been implementing beyond healthcare, so healthcare, education from home, work from home, is really highlighting the fact that we have to build up broadband infrastructure in really rapid ways. And then just an afterthought for most people, but there are some liability questions. With the expansion of telehealth, it's unclear how the FTCA protects FQHC providers if they're practicing from their homes, for instance. So there's still some lingering questions there. Next slide. So these are some of the policy levers that are available for implementing solutions. I do want to comment briefly about the act that did pass yesterday. So Healthcare Enhancement Act did pass the Senate yesterday. It's heading to the House tomorrow. It will provide $225 million specifically to rural FQHCs and rural health clinics. It is allocated for testing and related expenses, so it's unclear what kind of support this will have for the broader financial needs that were mentioned earlier in this webinar, but that is some good news coming out of Washington. So there's some brief options that I'll mention here. The 1115 and 1135 waivers that are under CMS. 1135 is how telehealth has been expanded. So this was the authority that was used to say we will reimburse the same from at home. We can waive some of the provisions that currently prevent telehealth. But 1115 are state-led demonstration projects, and there are some opportunities there for states to potentially look at, say, for instance, in Georgia, where we did not expand Medicaid under the ACA, are we able to expand Medicaid to those who have lost their jobs because of COVID? So that's some options that are there. We already have the existing FQHC, rural health clinic, and critical access hospital designations. Are we able to potentially expand those out in an emergency situation to stabilize hospitals that aren't currently labeled as critical access hospitals? There's the Coronavirus Economic Stabilization Act, so sort of the reserve funds that are held up by the Treasury to strategically distribute. We could look at how we disseminate those in a way that's going to further support the stabilization of the healthcare system. The loan repayment program is another option to support providers. Refunding the PPP and EIDL programs to ensure that businesses, including healthcare, can keep their doors open, and potentially looking at ways to prioritize healthcare organizations so that we don't have a vacuum once the pandemic resolves will be really critical. The advanced payment program, if we can look at ways to expand out that horizon of the recoup period. So under PPP, agencies are being given 10 years to do repayment. If we do something similar with CMS advanced payment, that could help prevent some of the back-end negative effects that could be coming. And the one thing I really did just want to mention, as I stated earlier, a lot of these solutions that are being implemented are things we've been calling for in rural healthcare for a long time. And outside of the pandemic, they would be helping dramatically stabilize what's happening in rural healthcare. And so we have a real opportunity here to memorialize some of these changes as we recognize the way that they do expand access to care and ensure access to quality, affordable care for all Americans, including rural. And those are my comments. Thank you.
Well, thank you so much, Jacob. And I want to follow up on the last comment you made, because it seems like from all of your comments that this COVID pandemic really exposes and magnifies all of the paradoxes and inequities that rural health systems have faced for years that many people have tried to solve, have tried to work on. And whether that be keeping your doors open and being there for your community when they need it, but grappling with, the low volume that comes with a spread out population, that kind of thing. Similarly, Scott, as you mentioned, the just-in-time inventory model versus the surge capacity, the public health funding, all of those things that you mentioned. So I wonder, and I'd love to start with you, Jacob, and then hear from Mike and Scott, can you speak to the immediate solutions that are needed versus how do you see these lessons perhaps being applied in the longer term, even if longer term is the next few years? But how do you see that sort of immediate emergency kind of response versus how do you see these lessons learned applying to what we were already struggling with when it came to rural health systems?
I think a lot of what we can do in the immediate is expanding out our concept of stabilization. And so while we are having a particular rural crisis here in Georgia, some of the other states aren't having that same effect. So as we send funds down through the existing mechanisms, so FUHCs are receiving support funds, hospitals are receiving support funds, if we can be sure that those are disseminated in a way that allows them to put them toward what they need. If that is that they need a PPE stockpile, great. If that they need to maintain their personnel because they're going to have to shutter their ER without it, we need to realize that that is a broader effect of COVID. And so being sure that we're expansive in how we are implementing these policies, I think, is one of the key steps.
Thanks. Scott or Mike, would you like to jump in?
Well, I can speak as an administrator of a hospital. That, for me, first and foremost, is making sure that we have the revenue to be able to continue to pay our staff and to be able to make sure that we have the equipment that we need. And that's been everything that I have worked on for the last 10 years because of the situation that rural health has been in. If we can't keep the doors open, then all the rest of it is academic. And so I think there has to be a different way that we view critical access hospitals, particularly ones that are located in more rural parts of the country, instead of thinking of them as all equal in terms of their ability to function. Critical access hospitals that are closer to urban areas tend to do better than critical access hospitals or rural hospitals that are located more out on the frontier. The two hospitals that I run are really out on the frontier, and so volumes are never going to be what you're going to see in the urban areas or in the critical access hospitals that are closer to urban areas. There are plenty of challenges that go along with that, such as provider and nursing recruitment and retention, and the cost of being able to bring those folks on board, which is much higher than you might find in an urban area. So there has to be a recognition that rural hospitals are vital to their communities, and that they're going to need assistance and support in order to be there. I often liken it to regarding us as more like a fire station. You don't necessarily want to think about the fire station, but you're sure glad that the fire station's there when there's a fire. And I think that's what we're seeing now. At least it's what I'm feeling. When I raised the flag with our State Hospital Association about our concern about closing, the effect of doing that was immediate and swift. I had calls from state officials and federal officials within the hour wondering what they needed to do in order to help us, because their comment was, we cannot have a hospital go down in the midst of a pandemic. And so that was heartening, but it sure would have been great to have felt that the last 10 years. And I think, again, maybe part of what, if there's a silver lining here, maybe part of what folks are recognizing is that every one of these hospitals plays a vital role in communities' health.
Thank you.
Hello. I'm sorry, this is Mike, and I wanted to also jump in here for just a moment. I think that having an increased reimbursement for telemedicine would help many facilities, both fixed and outpatient facilities, to have better income during this time when we've just had to shut off so much of our routine care, so that our capacity is vastly underutilized. But I think also having a bigger plan, a bigger vision for what health and healthcare will look like in the United States, and to designate rural hospitals, among many others, as critical infrastructure, and not only hospitals, but industry producers of personal protective items, pharmaceuticals, vaccines, all of those things together require some foresight. And really, there's only one organization that can do anything like that, and that's the federal government. And so I think moving forward, we have to use this pandemic as it magnifies the defects within our healthcare system to go back and fix things. Because again, we see the enormous financial and human consequences of failing to have a better public health system and critical infrastructure in our healthcare.
Thanks, Mike. And we already have some great audience questions coming in, so please keep them coming. I want to let me address a couple of them, and just kind of on this capacity issue. Mike, you mentioned telemedicine. One questioner asked, so much of rural healthcare is based on outpatient procedures, and so now with many of the elective procedures limited or prohibited, how quickly do you think patients are going to return to the hospitals or the providers like FQHCs for these kinds of services that are perhaps less time sensitive? Do you see the telemedicine sticking as far as a model going into the future? Mike, let's start with you, and then we'll go to Scott.
Certainly, expanding telemedicine beyond the pandemic is going to be a great solution. And that's why I think it solves so many issues. You can reach people remotely. And right now, our patients are typically staying away out of their own concern. Many of our elderly patients don't want to come anywhere near a healthcare facility or congregate anywhere. So people are self-selecting to stay away from our health centers right at the moment. But I think that's a really important piece, is being able to do this more in the future.
Thanks, Scott. Any thoughts on your end as far as whether people are going to return? How quickly do you think people are going to return? Still totally up in the air.
Yeah. I think it's going to be slow. I think for the folks that are fearful, I think that they're going to be cautious. I also think that telemedicine, it has been somewhat of a forced discovery, and I think some people are finding that they really like it, and I think they're going to want to continue that. But we have at least in our area, we have a very elderly community, and many are not interested or particularly able to use technology. We have quite a number of folks that we've been trying to get signed up for our patient portal through our EHR, and it's a bit of a struggle. We also have a high immigrant community because we're a rural agricultural area, and many of those folks are suspicious of technology and particularly telemedicine. So at least for us, I think that it'll be a gradual increase in volumes and a gradual acceptance of telemedicine, though I think there will be a segment who will embrace it now and want to continue it.
Thank you. And so let me ask you, there's one other question, Scott. I want to stay on you because there's a question around personnel needs. And the questioner highlights kind of another side of the surge capacity paradox, which is that as volume goes down, the personnel needs change. But have you heard of shortages of personnel around your state? And maybe Jacob and Mike, you can weigh in here as well. But how are personnel needs kind of changing throughout this pandemic?
I do think it's changing. I do think that there's more personnel available because we're seeing indicators of health systems that are furloughing folks and reducing their payroll expenses by decreasing, the salaries of folks. So I think I'm getting calls now and emails probably 5 times more than what I usually get for agency nurses and other temporary staff. So I do think that there's more availability in this current crisis. But I think when things go back, when we start to see increased volumes, I still think that the nursing shortage and the physician shortage is going to continue to be an issue for us. I think that the amount that we're seeing now in terms of abundance is short term.
All right, thank you. So I just want to remind everybody we have about 10 minutes left. This is a slightly extended webinar, so we have till 12:45. So if you still have questions, feel free to send them in. I want to turn to what's been going on with Capitol Hill and in the administration. And Jacob, I'll put you on the spot here. We've gotten a couple of questions here around the CARES Act and then the Healthcare Enhancement Act. Can you just share a little bit more about how do you see that funding working? Do you think it's been sufficient or will be sufficient to meet the current financial constraints for the rural hospitals? And then an additional question around, do you have thoughts yet around the distribution of the funding? Is it more likely to go to large hospital systems versus rural hospitals? Can you speak to that?
Sure. I was relieved to see in the Senate bill that there is a specific allocation for rural health clinics and FUHCs. I did not see a similar provision for rural hospitals or for critical access hospitals that are located in rural communities. So it's unclear how this will filter down. I think if we look at what rolled out with the general Paycheck Protection Program, we know that a substantial amount of those funds did go to larger agencies rather than smaller. So I think there are some logistical issues to work through in terms of how we prioritize small businesses and particularly how we prioritize small healthcare businesses, because that'll help us keep our primary care providers open, our smaller rural hospitals open, particularly those that don't have some type of federal designation. So there are a lot of hospitals and providers who aren't in rural health clinics, but are critical rural providers, even if they're not federally designated as such. So it's unclear how that will go out and what it can be used for, because even in the even in the bill that passed yesterday, the funding is still, per the words of the bill, allocated for testing and related expenses. And so it's unclear how that can be used for the broader stabilization needs of the groups.
All right, thanks. And Scott, you mentioned, talking to your state and your federal legislators. I mean, do you feel like there's more that can be done? And maybe I'll go back to both of you. I mean, are there any solutions that you feel like we're going to have, some bipartisan support, multi-stakeholder support that as we go forward, we can think about for the rural areas?
Yeah, I've been pleasantly surprised with the response that we've gotten on both sides of the aisle. Folks, I think, have been very supportive of wanting to keep hospitals whole through this. And so, as I mentioned earlier, I think there's been a recognition of how vital hospitals are to the health of rural communities as well as larger communities. So I have not received any negative or any kind of pushback from congressional leaders. The only thing that I would say is that I think people are grappling with the amount of help that is likely going to be needed and trying to figure out how they're going to fund that. The state has essentially communicated to us that they're out of tactics that they can utilize, and that they're really going to rely on the $100 billion that was passed through the CARES Act and future funding that may be coming. So I don't know that the county or the state has the resources to help us in the short term or even long term. So we're really looking to the feds to make the difference here.
So one of the things that comes up that I think complicates this discussion is very often, this is what plays out when we look at allocation of resources to rural communities. The larger systems with the larger numbers get the larger eyes. And so the proportionality of what's occurring in rural is higher, but we're not seeing that same proportional allocation of resources out into rural. So, for instance, our outbreak that we have in Southwest Georgia is not getting anywhere near the attention of the larger city outbreaks, even though the death rates are higher than in New York City and Southwest Georgia. So it's kind of important to be sure that we're raising this call all the time of saying, don't forget about the rural aspects of what's happening here, and that we need to be sure we're protecting in all these provisions how this can go out to rural communities. And there are federal systems in place to look at allocating need. We know that 3/4 of rural counties are health professional shortage areas, and there are hits of scores that could be used potentially in how we allocate some of these funds out. and there's prioritization that could happen in existing structures.
Thanks, Jacob. And you know, if you could comment maybe briefly on this idea of like this interconnectedness between the rural and the urban and the rest of the country, because I think if there's one thing this pandemic has shown us is that, you know, if we think about things in isolation, we're not going to be successful. So what are your thoughts there about how do you elevate that concept, or is that a concept that should be elevated? Like, you know, if we can't contain and reduce the severity in these rural areas, what does the outlook look like, not only for them, but, you know, for everyone else and for the course of the pandemic?
Exactly. We're seeing that play out in Georgia. We have our Emergency Management Association for Georgia, GEMA, has been releasing situation reports of ICU beds. And when you look at the ICU bed capacity in the region that I live in Macon, even though we don't have a high proportion, we're the tertiary center that is the catchment area for a large rural region of the state. And yesterday, we were down to 7 available ICU beds in the region, even though we don't have a local outbreak. And so, you know, I hate to try and put it on, it's going to come for you if you don't fix it in rural, but that's part of the dynamic that is playing out in a state like ours where we have been hit hard in rural. Even though the urban areas haven't been hit, they're having to take in the capacity that the local hospitals can't handle. And so it does really affect us all as a system.
Thanks. All right, we got a couple more questions. I do want to ask about this question around institutional settings in rural areas, other institutional settings. So maybe nursing homes or kind of other post-acute kind of things. Do you think, and Jacob, we'll just start with you, are there expanded roles, do you think, for rural hospitals to play in supporting people living in these institutional settings, either with infection control, surveillance, testing, quarantine, isolation, and in-place treatment? Like, what does the outlook look like for the interconnectivity between those settings?
That has been part of what's been discussed in these bills. I haven't seen a lot of it come out in language even, is how we can utilize this new telehealth infrastructure as a stabilization. So increase the volume by doing telehealth encounters facilitated in these long-term care facilities, nursing homes, et cetera. So it is definitely an option for how we step up from the way we view healthcare currently and make it a systems level approach of how we can integrate hospitals, local cares, long-term facilities into a care network. It's almost, you know, harkening back to the accountable care organizations, but not in the exact same vein. But just how can we really systematize that effect by bringing everyone to the table? And that is one thing that's happening with this outbreak, is those people are having to come to the table to discuss how we solve this. So I'm hoping that that becomes a long-term strategy.
Great. All right. I want to spend our last few minutes going to some broader public health issues, and these were touched on at the beginning, but as we know, several states, Georgia, South Carolina, Tennessee, and Texas, have all expressed that they wish to partially ease social distancing in the next few days. We certainly know these states will have significant health disparities between rural and urban areas. So want to ask each of you to speak to that, but since we only have a couple of minutes, I'm going to combine that with some things that Scott said at the beginning around, you know, the response of the community from panic and disbelief to you know, complying, I guess, with social distancing. Can you each speak to how do you think that dialogue needs to go with the rural communities and listening to their concerns, but also kind of communicating the public health guidelines? Mike, can we start with you?
Yeah, thank you. I think there's a lot of things that come to mind with just the couple minutes we have, but what we've not done well, I think, at a national level is really this whole idea of risk communication, expressing what the risks are to everyone, and the plethora of misinformation that's out there that's driven sometimes by people with legitimate concerns about their livelihoods, but other times people with nefarious intent is a real problem. And I think we need to really, our leaders, I would hope, would need to go back to the drawing board and look at risk communication. And that's something I think that our state government in West Virginia has done better. They've really gotten their message to the population. That's what really can help inform good policy, is having good information. And without that, we're kind of lost.
Scott, any thoughts about how you see the conversation going with your communities in the next coming weeks and months?
Yes, we have local newspapers that run the gamut of being very supportive of these measures that we're taking to contain the virus, to ones that are calling for the abolition of all of the measures and calling what's happening a hoax. And so we find ourselves often being asked to respond to that. And so we're working with our public health department. We're working with each other as healthcare entities to present a unified voice of science-based reason about why the things need to be the way they are. I think beyond that, we have to set a good example of practicing the very techniques that we've been advocating everyone else practice, both at each hospital, but in our personal lives. And I think, again, it's more communication. The right kind of communication is better, and if you think you're communicating enough, you're not. So it's just constantly making sure that you're out there helping to reach those folks that either haven't gotten the message or are skeptical of the message, and helping them to understand what we really need from them.
Thanks. And Jacob, we'll give you the last word as you look to the coming weeks and months. What are you looking for as far as, you know, how to both help the populations in rural areas, but also kind of communicate the risks and the trajectory of the disease?
Sure. This is kind of on everyone's mind right now in Georgia. For anyone who's been watching the news, you know that our tattoo parlors, bowling alleys, et cetera, will be opening in 2 days. And that's by governor decree that has overridden local ordinances. So there's a lot of discussion now about the voice of rural communities in that process, particularly given our rural outbreak. So the case example is that in Dougherty County, we've had 103 deaths among 88,000 residents, as opposed to Atlanta that's had 106 deaths for 1.8 million people. And we were starting to institute a one-size-fits-all approach within our state by opening businesses in a staggered manner, but it does not allow for local control over that process. So I think it's just really important to recognize, we talk about in Georgia, we have two Georgias. We have Metro Atlanta and then we have rural Georgia. And so it's important to recognize that we're probably going to need different strategies in this process, in risk communication, in resumption of activities. And I think it'll be really important for all states to keep that in mind, that this needs to be driven by local data and local information, and local municipalities, et cetera, need to have a voice in the process of what they believe is in the best interest of their communities.
Well, thank you, Jacob, and that's a perfect segue into the next webinar in our series, which will take place this Friday, April 24th from 2 to 3 p.m., and we will talk about the surveillance infrastructure, the testing and isolation surveillance infrastructure that is needed to safely reopen. So Scott, Michael, Jacob, thank you so much to all of you for joining us. To our audience, thank you for staying with us and for listening in. A recording of this webinar will be available at allhealthpolicy.org very soon. We wish you all well and be safe and healthy. And thanks again.
Thank you.
All right, this concludes the webinar. Bye, everyone.